Much. Well, good afternoon. I'm Dr. Bruce Vanderhoff, Director of the Ohio Department of Health. Sadly, we continue to see an uptick in COVID-19 cases and hospitalizations. Yesterday, more than 8,900 positive COVID-19 cases were reported in the previous 24 hours, with 425 hospitalizations. These numbers are comparable to what we were experiencing at the peak of our fall surge. Indeed, the last time we saw 24-hour case numbers this high was on September 10th, when we saw more than 9,000 cases reported. Similarly, at the peak of our fall surge, we saw a total of more than 3,700 patients hospitalized with COVID-19 across the state, reaching that high figure on September 27th. Yesterday, we reported more than 3,800 inpatient COVID hospitalizations, higher than at its peak during our fall surge. In fact, the last time more Ohioans were being treated in the hospital for COVID-19 was all the way back on January 12th, when 4,000 patients were hospitalized across the state. Now, much as we discussed last week, these cases aren't necessarily occurring evenly across the state at any point in time. We're seeing fluctuations in cases in different regions and different counties. Currently, we're seeing the highest incidence of new COVID-19 cases in the northern portion of the state, with the highest concentration of hospitalizations in the northeast corner of Ohio. When we look at trends across ages, what we see is that younger Ohioans, specifically those between the ages of 23 and 49, have a case rate per 100,000 that's 25% higher than the statewide average. And of course, when we look at those who are hospitalized with COVID-19, they continue to be largely the unvaccinated. The COVID-19 vaccines, as we know, are designed to protect us from severe cases resulting in hospitalization or death. So while someone who's fully vaccinated may in some instances still catch COVID-19, they are far more likely to be able to weather that case at home rather than ending up in a hospital or on a ventilator or in the obituary pages. Although we are, of course, very concerned about the high number of hospitalizations, particularly in Northeast Ohio, our strategic hospital zone system allows our hospitals to work together to address patient needs, discuss approaches to shared challenges, and shift some care within and between regions. Joining me today to discuss what hospitals in Ohio and across the country are facing is Dr. Andy Thomas, the Ohio State University Wexner Medical Center Chief Clinical Officer and Zone 2 Hospital Lead. Dr. Thomas, in Ohio, as well as other states across the country, hospitals are seeing very high numbers of patients. I've just reviewed some of those numbers, both those with COVID and those who have other medical conditions and other needs. Can you refresh our memory on how Ohio's zone structure works and has allowed hospitals to help one another?
I'd be happy to, Bruce. Thanks for having me here today. So the three zones were set up back in March of 2020, and it took Ohio's 8 emergency management regions that were really set up for things like tornadoes and floods. And we realized that the way patients flowed within our state didn't really make for 8 regions, but 3 made more sense. So the Zone 1 stretches all the way from Toledo across through the Cleveland, Canton-Akron area over to Youngstown in the northeast part of the state. Bob Wiley, who's Chief Clinical Officer or Chief of Clinical Operations at Cleveland Clinic, is the lead in Zone 1. I'm the lead in Zone 2, and we stretch from Columbus and the contiguous counties around Franklin County all the way northwest up to near Bell Fountain. And then essentially everything down 23, down 33, and out 70, that southeast quadrant of the state. And then Rick Lofgren, who's the CEO at UC Health, leads Zone 3, which are the Dayton and Cincinnati metro areas, and then all of the counties that surround Dayton and Cincinnati in the southwest quadrant of the state. I can speak best about obviously what happens in my own zone. I can tell you that we on a daily basis during the week at 9 a.m. have over 40 hospitals and health systems across Zone 2 on a call where we literally walk through hospital capacity, COVID census, and the ability of hospitals to accept transfers from other hospitals across the zone each day. We can get through, because we've been working together now for 20 months. We can actually get through that work usually in about 15 to 20 minutes and share a lot of information quickly. We've had to move PPE, we've had to move ventilators, we've had to move other medical equipment around between hospitals in the zone. Then also what we call lateral transfers is where we move patients from one community hospital to another, where traditionally they might have come to one of the Columbus health systems. We've been able to build partnerships between community hospitals where they are working together to make sure that the right patient is cared for at the right time with the right resources in the region. We've had hospitals that have had everything from computer system issues to other weather-related issues, needed to shift patients. It's been just a really rewarding partnership, and I think something that if you look across most of the states in the country, they've not built this sort of a system with collaboration between the state, between your office, between the governor's office, the Ohio Hospital Association, and then the individual hospital zone leads across the state. It's been very rewarding and I think very helpful in making sure that we've been able to weather this pandemic as well as we have.
Thank you, Dr. Thomas. You know, as many people listen to these very, very high numbers, not only cases, but hospitalizations, I'm sure many are thinking back to the early days of the COVID-19 pandemic when we shared that our hospitals were making plans for expanding the number of beds they had available by building auxiliary facilities, tent hospitals, and other surge plans. However, the problem right now isn't really necessarily physical capacity or physical beds, but staff. Can you share with us a little bit about the challenges that Ohio's hospitals are facing and how Ohioans can really help to lighten the load that is being borne right now by our hospitals and health systems?
I sure can. So a couple of things related to capacity issues. One, I think you're exactly correct, Bruce, that staffing is a major limitation at most of the hospitals in my zone, and I would say most of the hospitals across the state. We've seen news reports of hospitals that have needed to close beds. And I would say almost every hospital really doesn't have that same elasticity that maybe we had this time last year to really be able to expand capacity on a short-term notice when there's a flood or a surge of patients in your local region. The fact that hospitals have beds closed means that you're really capacity constrained, not just for COVID patients, but for patients that have a heart attack or patients that have a trauma that maybe in the past would have been taken care of at their local hospital. But now those patients are going to need to be moved to a different community just because that hospital already has 10 or 15 admitted patients in their emergency department. I think in the northeast part of the state, as you highlighted, those concerns are of even a greater degree than they are right now in the central part of the state or in the southwestern part of the state. We actually had a call yesterday between some Zone 1 and Zone 2 hospitals looking at sharing patients between zones just because they're really in a difficult spot in the northeast part of the state. And to your point about what people can do to help, it's really about vaccination. To your point earlier, Bruce, I think that certainly individuals that are fully vaccinated or in some cases even fully vaccinated with the booster may get a breakthrough case. I think there's also ample evidence that the risk of getting an infection if you've had a significant exposure is far less if you're vaccinated. But what's really important, at least in what we've been talking about, is the opportunity for you to get vaccinated means you don't have or you're at lower risk, I should say, of developing pneumonia, of developing low oxygen, of needing to be in the hospital, in the ICU on a ventilator, or God forbid, passing away. And that's really the game changer that will help Ohio's hospitals in your hospital, in your local community. When you go in with a gallbladder attack, or when you go in with a cellulitis on your leg and they're saying they can't take care of you and you're being shipped an hour away, it's partly all of these things. Patients are sicker. Our length of stays are longer because a lot of those patients that maybe sought to put off care during the pandemic are showing up sicker with non-COVID issues than they did before. But really the ability of folks to get vaccinated will reduce that number of cases, will reduce that number of hospitalizations, and allow us to make sure that we're maintaining the flow of patients and the quality and safety of our care moving forward across the state.
Thank you very much, Dr. Thomas, for that very good explanation. At this time, while we face very high cases and hospitalization statewide, Delta remains the dominant COVID-19 variant in Ohio. As you'll likely recall, we detect variants by way of genomic sequencing, which is a process we've been engaged in now for many months. Genomic sequencing is performed on a positive PCR test sample when enough of the original sample remains and there's a high enough viral load in that sample to then go on and do further genomic sequencing. On the other hand, most of our rapid home-based antigen tests can't be sequenced. So on any given day, only a subset of all the positive tests out there are able to be sequenced. And the process of sequencing itself can take a few weeks. In many cases, the genetic code is associated with a particular variant that has been given a Greek letter, Greek name like alpha or delta. In some cases, it may be associated with a variant that hasn't yet been labeled, a variant of concern or variant of interest by the CDC. In either case, the identified variant is cataloged. And if that variant later is labeled as a variant of interest or a variant of concern with a Greek letter, it will show up on our dashboard with the Greek letter name. If not, it's labeled under the gray other section. So in short, genomic sequencing is conducted on as many PCR samples as possible, both by the ODH lab and the other labs across our state, which report the results right back to ODH. Now, because we're sampling as many PCR tests as possible, if the Omicron variant shows up in Ohio, we'll likely see it reasonably quickly in our state's genetic sequencing data. Now, speaking of the new Omicron variant, much remains unknown at this point, including whether it's more transmissible or capable of causing more serious illness. Early reports have suggested a tendency of the variant, the Omicron variant, to produce mostly mild illness, but that's based on very limited reports. Also, early indicators are that infection with Omicron could result in a positive PCR or antigen test despite its many mutations. So if you become sick with COVID-19, you should continue to seek testing, even if we start seeing this new variant here in Ohio. And remember, our diagnostic tests are designed to tell you whether you have COVID, not which variant you have. The importance of a positive COVID test is the knowledge that you need to isolate yourself and treat your illness, not the particulars of which variant is responsible for causing it. We do that more at a population or epidemiologic level. Now, of course, we expect to learn a lot more about Omicron over the coming weeks. But what we know now is that it has more than 30 mutations on the spike protein alone, so a lot of mutations. And these distinctive mutations actually allow us to identify the variant when a lab sample is then genomically sequenced. The variant, as you know, has now been identified in California. If and when it arrives in Ohio, rest assured, we'll be looking for it. So we don't know yet if Omicron will be more contagious, cause more severe or less severe illness, or be more deadly. But let's remember that there were other variants of concern, ones like Beta and Mu, which spread rapidly in other parts of the world, but actually never took hold here. Now with Omicron, as in the past with new variants, it is time that will tell the story, and we will be watching very closely. Importantly, at this time, we have no indication that our vaccines will fail to provide substantial protection against even Omicron. Especially, we're reassured that it does appear to, our vaccines do appear to protect against severe disease. In fact, Dr. Angelique Coetzee, who chairs the South African Medical Association, has shared that South Africa's hospitals were not overwhelmed by patients infected with the new variant, and that most of those hospitalized with Omicron, in fact, were the people who weren't fully immunized. This means that as we anticipate the potential emergence of Omicron right here in Ohio, there's a very important step that you can take to protect yourself and your community, and that's to get vaccinated. Don't delay your COVID-19 vaccine. If you haven't yet chosen to be vaccinated, go get your first booster today, your first dose today. Obviously, if you're eligible for a booster, get that today. With cases and hospitalizations on the rise from the Delta variant, and with a new variant right on the horizon, now is the time to protect yourself. Now, speaking of rising cases, especially amidst the cold and flu season that we're also now in, it can really be difficult to know whether you have COVID-19 or something else if you've got upper respiratory tract symptoms. So if you're showing symptoms of COVID, these are symptoms like cough, sore throat, fever or chills, headache, congestion, difficulty breathing, other upper respiratory symptoms, or if you've been exposed to somebody with COVID-19, you really should get tested. COVID-19 tests are readily available throughout the state of Ohio. Many pharmacies provide free drive-through testing by appointment, which you can often make the same day. Testing may also be available at your doctor's office or an urgent care or community health centers. And of course, free rapid testing kits are available at libraries, local health departments, and community health centers across our state. Although the rapid testing supply market is, in fact, still very limited nationally, thanks to strategic purchasing and distribution, Ohio has been able to maintain adequate supplies of rapid at-home testing kits. At this time, we have sufficient supply of COVID-19 test kits and are replenishing them as quickly as possible upon request. To date, the Ohio Department of Health has in fact distributed nearly 3.8 million free rapid testing kits. So if you become sick or are exposed, know that there are many options for testing available. If you test positive on a rapid antigen test, so one of those home tests, and you also have risk factors for exposure to the Omicron variant, such as recent travel, I'd really ask you to consider getting a follow-up PCR test, which can then be genomically sequenced and help us determine whether or not you might have one of the early cases of Omicron. And remember, if you test positive for COVID-19 and begin to experience severe symptoms, there may be treatment options available for you. Contact your healthcare provider or seek medical attention promptly. Now, today I am joined by Dr. Stephen Gordon, the chair of the Department of Infectious Diseases at the Cleveland Clinic. As we've discussed, we're seeing very high hospitalizations across the state, Dr. Gordon. Monoclonal antibodies, of course, have been proven to be very effective treatments for many of those at high risk for complications from severe COVID-19. Could you share with us, what are monoclonal antibodies? How do they work? And when and for whom are they most beneficial?
Well, thank you, Dr. Vanderhoff. And I want to emphasize, although we're going to be talking about treatment, our best prevention right now remains vaccination. So when we talk about neutralizing antibody therapy, it's been around for quite some time. And these are neutralizing antibodies that are actually derived from the convalescent plasma of recovered patients. And there's at least 100 or so neutralizing antibodies that have been FDA approved from diseases ranging from cancer to HIV. Now, when we're focused on SARS-CoV-2, it's important to recognize that we have 3 products that are authorized for emergency use, but not FDA approved. And the indications, as Dr. Vanderhoff mentioned, are for early mild disease, meaning patients who are not hypoxic, that is, have no big oxygen requirements, in early on in the disease. And this is for adults and even pediatric patients that are above about 82 pounds. I want to emphasize, though, that it's still a lot of barriers because it requires a positive test. It requires an intravenous infusion that has to be observed because there is the possibility of anaphylaxis. It's a one dose infusion. And as I said, it's going to work early if it's going to be effective, meaning before our own bodies have developed antibodies. So there's a time-sensitive window in there. Where we found a lot of confusion is patients who are already admitted or sick with pneumonias, patients or families are asking for the monoclonal antibody. And early studies show that it is not effective in that arena. And in fact, we have other treatments that we go to. The other space where monoclonal antibody is used is before the onset of infection, but maybe exposure, especially to the high-risk patients who have not been vaccinated. And in our experience, that has been a little bit put on the back burner because of the increase in cases in the focus on trying to get patients, as Dr. Vanderhoff has said, who are at high risk with early testing positive for COVID-19.
Dr. Gordon, of course, we've all heard that the FDA is evaluating oral therapeutics from two manufacturers at this time that are designed to treat COVID-19. But we've also heard that when they become available, they'll likely be initially in very tight supply. So although these aren't yet available, how could COVID-19 pill treatments act to supplement the existing monoclonal antibody therapies and help treat patients who are suffering from COVID-19?
Another great question and another great opportunity. So this, our focus initially was on vaccine. Therapeutics kind of took a back seat. And in fact, if you look at FDA approval drugs for COVID-19, we only have one, remdesivir for inpatient. So the outpatient space is, as we said, wide open. Right now, the only therapeutic we have is monoclonal antibody, but as we talked about, that's cumbersome. So if we had an oral option that was more effective or as effective, that is clearly now a key focus. Many of you heard about earlier this week, molnupiravir, which is Merck's drug, went in front of the FDA advisory committee. And I would say it got a lukewarm approval at best. And when you look at the data, you can see why. Now, this drug is named after Thor's hammer. It is a broad antiviral for RNA viruses. In fact, was first looked at for influenza. It is a prodrug, meaning it's well tolerated orally and then converted in cells to the active component, which then affects the RNA polymerase of viral replication. The initial abstract that was reported in early October was looking at about a 50% relative reduction in patients at high risk for hospitalization with early COVID versus placebo. When we looked at the data that was presented at the FDA, that dropped to a relative risk of 30% and an absolute risk of hospitalization or death of only 3% between placebo and control. So you can see why it's a little bit tepid. But nonetheless, 40 pills taken over 5 days. Again, timing would be crucial like monoclonal. So as Dr. Vanderhoff said, it's got to be linked to testing and accessible testing, and then obviously then release of the therapeutic. The other kid on the block, which we have not seen any data on, is Pfizer's Paxlovid. This is linked with another protease inhibitor, ritonavir, which those of us in HIV are well recognized. The preliminary report looked at a relative risk improvement of hospitalization or death or outcome of almost 90%, but we have not seen that data. They will also go up in front of the FDA advisory committee, so we'll learn more. So what I would say on both is these are, I don't think we have a home run yet in terms of here, and certainly it's not right in front of us. And so again, we pivot to control what we can control. And these are the things that Dr. Vanderhoff has continued to emphasize: vaccination, boosting, and again, non-pharmacological interventions for those at risk to prevent acquisition of all respiratory viruses, but including COVID-19.
So Dr. Gordon, on that note, COVID-19 boosters, of course, have been fully authorized for vaccinated adults 18 and older. And so for those who received an mRNA vaccine, we're talking about eligibility 6 months after their second dose, while for the J&J recipients eligible for the booster of their choice, 2 months following the first dose. Could you tell us why are these booster doses important, especially in the context of new variants like Omicron on the horizon?
Another excellent question. And we are learning as we move along. So we have other examples of vaccines. I would say our seasonal influenza, where it's not a one and done. And even some of the ones we're looking at adolescents are series vaccines or vaccines where you need potential boosting. For respiratory viruses, which can be tricky, it's no surprise, I think, and it was anticipated that we were going to need boosting. And in fact, this might turn out to be a situation where annually we'll get an influenza combined with a COVID booster. What may change though, and again, this is what we're all talking about now, is with the mRNA platform, you might be able to target boosters selecting for things that are circulating or more worrisome variants. So it won't surprise me to begin to see, as we anticipate, and already the companies are talking about potentially getting an Omicron booster ready. Right now, the boosters you're receiving for the mRNA are the same that we receive for the primary vaccine, except for the Moderna booster is half the dose. But you can see where this may go. And again, it's going to be the epidemiology and the science that will drive it. But we have now the technology and the platforms, and we have the doses available here in the homeland to, again, get that boost. So your immune system, again, begins to see, you'll get that elevation in antibodies. And the hope is, of course, that will also help not just for Delta, but potentially for other variants that we have not seen yet in terms of protecting against severe disease. And I think that was another important point. We're not looking for sterilizing immunity. If I walk away with a breakthrough with a cold, I'm comfortable with that. It's the hospitalizations and death that are really the key markers here for efficacy.
Yes, thank you so much, Dr. Gordon. Next, I'm joined by Dr. Carrie Warshak, a UC Health physician and professor of OBGYN at the University of Cincinnati College of Medicine. Of course, Dr. Warshak, we know that the CDC, the American College of Obstetrics and Gynecology, and the Society of Fetal Medicine have all recommended COVID-19 vaccines for pregnant women. However, the majority of pregnant women still remain unprotected by vaccines. Dr. Warshak, we know that a woman's immune system changes during the time that she's pregnant, putting her at greater risk for the complications of COVID-19. Could you share with us a little bit about the risks to a pregnant woman who becomes ill with COVID and how those risks compare, for example, to their non-pregnant counterpart?
Sure, thank you. And first of all, let me thank you for inviting me to participate in this briefing today. Yes, you're exactly right. Pregnant women characteristically are predisposed to more complicated courses with many infections, such as the flu. With COVID, we have not found pregnant women necessarily to be more susceptible to becoming infected. However, we have found pregnancy does increase the risk of severe infection. Thankfully, similar to non-pregnant women, about 90% of pregnant women will have uncomplicated courses that either have mild symptomatology or even asymptomatic courses that do not require hospitalizations. However, there are now consistent and alarming reports that the rates of severe COVID are much higher when infection occurs during pregnancy. For example, we have found that pregnant women are 2 to 3 times more likely to require mechanical ventilation and ECMO compared to non-pregnant women that are age matched. That we've also found they're 18 times more likely to require an ICU admission. But of course, pregnant women are at increased risk for medical issues. So a recent study sought to look at this a little bit differently, and InterCovid compared pregnant women who become infected with COVID to pregnant women who do not become infected with COVID. They also found much higher rates of ICU admissions, a 5-fold increase. And of most concern, they reported a 22-fold increase in the risk of maternal death in pregnant women who become infected with COVID. Again, compared to pregnant women who do not become infected with COVID. They found higher rates of earlier delivery as well as blood pressure disorders of pregnancy, such as preeclampsia. So although the majority of pregnant women will have mild infection, there is no doubt pregnancy is absolutely a risk factor for severe COVID. I would also add that the management of pregnant women who get very sick with COVID is often very, very complicated, secondary to the needs to balance maternal risk and benefits versus fetal risk and benefits.
Yeah, thank you, Dr. Warshak. With all of that context, I know that an additional concern that most pregnant women have is just about safety and safety of whatever they are putting into their bodies during pregnancy. Can you share a little bit with us about the safety of the vaccines? Are COVID-19 vaccines safe during pregnancy? Does getting a COVID-19 vaccine, for example, increase a woman's risk of a miscarriage?
Yes, absolutely. I hear and discuss these concerns every day face to face with my patients. So I'm very well aware of the multiple and varied concerns that pregnant women have regarding vaccination and pregnancy, and for good reason. Pregnant women are generally very reluctant to start any new medication or have any unnecessary exposures. As physicians and OB-GYNs and maternal fetal medicine physicians, we are very cognizant and respectful of these concerns. However, the bottom line is all indications are that the vaccine is very safe and even more effective at preventing critical COVID than we had even initially predicted in non-pregnant individuals, and thankfully in pregnant individuals as well. One example is the CDC V-Safe app, which has collected 36,000 participants that indicated that they were pregnant at the time of vaccination. Remember, 94% of these participants were healthcare professionals, so they were therefore very knowledgeable and reliable study subjects. Pregnancy outcomes that they have reported showed no indication that there's a higher risk for any of the common causes of concern for women that are pregnant. Notably, the risk of miscarriage was reported at 13%. That is absolutely similar to historical rates that are reported in rates in non-vaccinated women. The rates of birth defects was 3%. Again, that is no different. The rate of preterm delivery was 9%, no different than historical rates or rates in non-vaccinated women. They did have one reported stillbirth. That risk then was reported as a rate of 0.1%. And again, we generally report the risk of stillbirth in any pregnancy is somewhat less than 1% historically. So very much similar to what we would expect to see in that many women. We are expanding data, both observational and based on clinical experience. All of this has not identified any safety concerns for COVID vaccination. I guess I would say to all the pregnant women who may see this, the best way to protect your baby is to protect yourself. We have a safe, proven, reliable weapon against this virus, and that is vaccination.
Thank you, Dr. Warshak. One final question, and that's in regard to boosters. Some individuals may have gotten vaccinated before they got pregnant. Now they're pregnant, wondering about boosters. What would you recommend to them regarding getting a booster?
Yeah, so far the recommendations for vaccination for pregnant women pretty much have mirrored those for non-pregnant women. ACOG does recommend that pregnant women and women within 6 weeks of their delivery receive the booster as recommended by the CDC. This recommendation is based on their vast experience with use of the vaccine in general. And in pregnancy, there's really no reason to believe that the booster would pose any new or additional risk. I would also note that we have done studies and do know that the vaccine produces antibodies, and those antibodies can be found in the fetal circulation and cord blood. Even 15 days after the first shot. We also know that they pass into breast milk. And I believe that as research evolves, we will confirm that there is likely a neonatal benefit to maternal vaccination and booster vaccination in pregnancy or during breastfeeding.
Thank you very much, very helpful. Well, COVID-19 on an individual basis can really be very unpredictable. One person may have an asymptomatic case while their neighbor who looks just like them could end up hospitalized. A friend may have mild disease, and yet one of their relatives could pass away following a severe illness. If you're unvaccinated, there is simply no way to tell which fate could befall you if you become infected with COVID-19. If you're unvaccinated, you're vulnerable to COVID-19 and potentially to the lingering effects of long COVID. Those who have chosen to be vaccinated, however, we know are well protected from severe illness and death. If you're not yet vaccinated, please go get your shot today. And if you're eligible for a booster, don't delay that. Protect yourself today.